Good evening all. I, Miss Pallavi Nandi, welcome you all to the third day of webinar series hosted by JSS College of Physiotherapy on the occasion of World Physiotherapy Day. So far, we have conducted 4 webinar series where thousands of participants has joined. It is my immense pleasure to introduce today's speaker, Dr. Neha Dewan, to all of you for today's webinar. Dr. Neha Dewan has completed her Master in Orthopedic Physical Therapy as a hand rehabilitation specialist in the year 2010. She has completed her PhD from McMaster University, Canada in the year 2016. She has recently completed her postdoctoral fellowship from Lakehead University. Currently, she is working as a tutor at McMaster University. On behalf of JSS College of Physiotherapy, I welcome you, ma'am. Over to you, ma'am.
And hello, on my behalf too, I welcome you, Neha. She was one of my star students and I'm very proud to be listening to her talking.
Over to you. Thank you so much, ma'am. Okay, hello everyone and good evening, I believe in India to everyone. So I am Neha, as my introduction is already well given by Pallavi, and I am proud to be a student of Dr. Kavita Rajas. To start my talk, I'll be today talking about recovery and secondary fall and osteoporotic fracture prevention after distal radius fracture. This is something which is not very common for all of you to hear, but I hope I should be able to provide adequate information to you about this novel topic in the area of distal radius fracture today. So in this talk, as an overview, I'll be talking about the research problem which I have focused in this project and specific research objectives. I'll be providing summary of some of the research findings from studies which I have conducted in the last 4 or 5 years and how these studies have contributed in the field of rehabilitation science and clinical practice. I'll also discuss about limitations, strengths, and future direction of the research project which I have conducted in the last few years. So to start with the research problem, where I was very much interested when I moved to Canada for my PhD was falls, osteoporotic fractures, and in particular, I was interested to work in the area of distal radius fracture, secondary falls, and osteoporotic fracture after distal radius fractures. So what is distal radius fracture is very well known to all of you. It's a break in the bone in the distal articular surface of the radius about 2 centimeters above the corticocancellous junction in the distal part of the radius. And it's one of the very common fall related fracture which usually occur after a fall from a standing height or lower. So why I'm talking all about this is because I want to relate it to something called as osteoporotic fracture or fragility fracture. So now, why I want to start with falls and osteoporotic fractures is because of the high rate of burden. Fall-related injuries are known to be second leading cause of accidental deaths. And in terms of burden of falls and osteoporotic fracture, if you see among older adults, research suggests that every 11 seconds, there's one admission to the emergency department as a result of fall. And every 19 minutes, there's one death as a result of fall. There's one osteoporotic fracture taking place every 3 seconds, and 90% of all these osteoporotic fractures, they result from a fall. And if you look over here, 1 in 5 falls often lead to serious injuries, including fractures. Now, if we talk about distal radius fracture, it's not a very serious injury or a very serious fracture, as you all know. However, if we look on the prevalence of distal radius fracture, this is a data from one of the long bone fracture study, which says that radius was one of the most commonly fractured bone over here, if you see. And if you look on the socioeconomic burden, it results in high healthcare costs to the society and the healthcare system. Now, distal radius fracture is a fracture which is very common in elderly, more than 50 years of age, and it's 5 times more prevalent in women than men. Now, this was regarding distal radius fracture. Now, I want to discuss about secondary falls and osteoporotic fracture after distal radius fracture, why it's important to talk about this topic. And it's because a fall-related distal radius fracture, this indicates that there is an elevated risk for future falls. Globally, it's seen that first fractures are often associated with 86% increased risk of future osteoporotic fracture. And there are studies showing that distal radius fracture in itself is an early and independent predictor of secondary osteoporotic fractures. Again, in a large study from North America, it was seen people who had distal radius fracture, they were at risk of secondary wrist fracture by 3-fold and secondary osteoporotic fractures at other sites by 2-fold. Now, why I'm saying the distal radius fracture puts the people at risk of secondary falls or osteoporotic fracture? This is because it's seen that people who have distal radius fracture, nearly 80% of those people are reported to have increased bone loss. And more specifically, these studies were among postmenopausal women. And why it happens is because there is reduction in estrogen level following menopause. Now, this when combined with distal radius fracture, what happens? People are not that active after wrist fracture as they were before in terms of the sporting activity or activities of daily living or normal functional activities. So what happens? Their physical activity level decreases. Their muscle strength decreases because of overall decrease in the physical activity. Their postural balance decreases, coordination and reaction time decreases. And this is not something I'm saying from my experience or like from my own study. It's because of the previous literature review. This is what I found. And this all together, along with the increased bone loss, put the people at increased risk of secondary falls and osteoporotic fracture. And there comes the role of modifiable risk factors. So if we see all these factors, starting from bone loss, physical activity, muscle strength, balance, coordination, reaction time, all these are modifiable risk factors. Now, what I was interested in knowing, what is the clinical practice pattern in assessment and treatment of patients with distal radius fracture? As a hand therapist in India, what I saw, the focus of rehabilitation for these patients were mainly towards managing wrist hand pain or maximally rehabilitating up to the shoulder. However, we were not having any holistic approach to manage these patients. And while I reviewed some literature and conducted my own study in terms of looking on clinical practice patterns for subsequent fall and osteoporotic fracture prevention for patients with distal radius fracture, what I found from my literature review and from my own studies, that there are already existing studies which says that there are assessment tools, measures, and intervention strategies which can be used for secondary fall and osteoporotic fracture prevention in patients with distal radius fracture. However, when audits were done among provinces like Manitoba, Quebec, or Ontario, nearly 80% of the patients with distal radius fracture, they were not assessed or managed for secondary fall and osteoporotic fracture prevention. And same was the case, what I found in my survey study, that these therapists, nearly 85% of the therapists said they have knowledge, they have awareness about the tools, what they can use to assess, treat, or refer patients for bone health assessment. However, nearly 75% of the therapists, they were not using any of the tools or intervening patients for fall osteoporotic fracture prevention or referring their patients for detailed bone health assessment. So there was definitely a research gap, that there is high quality evidence on multi-component fall risk screening and physiotherapy interventions which can be used for screening and management of patients for secondary falls and osteoporotic fracture prevention in patients with distal radius fracture. However, more than 75% of therapists, they don't even screen these patients for secondary falls and fractures. So there was a gap, and this gap we thought is because there's lack of clear understanding and objective evidence on what role these modifiable risk factors play in secondary fall or fracture prevention among patients with distal radius fracture. So the purpose of the research project was to explore the recovery patterns in modifiable risk factors and provide a quantitative evidence what role these modifiable risk factors would play as a predictor of bone mineral density, secondary falls, and osteoporotic fractures after distal radius fracture. So, modifiable risk factor, again, to review, what I'm referring over here are balance, physical activity, fear of falling, wrist hand pain, bone mineral density, and health status. So the research question what we had is how these modifiable risk factors would change over 4 years after distal radius fracture, and whether they would differ with respect to gender, age, incidence of subsequent falls, and osteoporotic fractures. And to what extent these baseline modifiable risk factor can predict bone mineral density in patients with distal radius fracture. And lastly, we were also interested to know to what extent these baseline modifiable risk factor can predict secondary falls and osteoporotic fractures at 4 years after distal radius fracture. So, in terms of study participants for all these 3 studies, we recruited 50 to 80-year-old men and women with distal radius fracture from the Hand Upper Limb Central London, Ontario. It's one of the largest centers where we receive maximum number of referrals for patients with distal radius fracture. And this sample range across 3 studies, sample size was between 94 to 190 subjects. Mean age of these participants was 63 plus minus 8 years, and majority were females, as we could expect. And in terms of bone status, if we look at the baseline, nearly 40% of the patients with distal radius fracture were actually had osteopenia or osteoporosis. And these patients were assessed at baseline, 6 months, and 4 years after distal radius fracture. Now, to answer first research question, that is how modifiable risk factor would change over 4 years after distal radius fracture and whether they differ with respect to gender, age, incidence of subsequent falls, and osteoporotic fractures, we conducted our first study to look on recovery patterns for these modifiable risk factors. And in this study, we actually assessed our patients using self-reported outcome measures. We used patient-rated risk evaluation questionnaire to assess fracture-specific pain and disability. It's 100, this questionnaire actually scores from 0 to 100. And what happens if higher the score means high rate of pain and disability. To assess physical activity, we used self-reported questionnaire called as Rapid Assessment of Physical Activity. And this questionnaire ranges from 0 to 10. And again, higher the score means higher the level of physical activity. Fear of falling was assessed using modified fall efficacy scale. And this was also scored on a scale of 0 to 10. Higher the score means high fall efficacy or less fear of falling. And for health status, we use SF12 health survey. And for in this also, if higher the score, more particularly if score is more than 50, it means good perception in terms of physical health or in terms of mental health. And for bone mineral density, we use a gold standard method, that is DEXA. We use age, gender, secondary incident falls, secondary incident fractures as covariates. And for analysis, descriptive statistics and general linear models were conducted to assess change over time. Now, in terms of findings from this study, what we found is in terms of demographics, as we could expect, there were 62% patients who were in the age group 50 to 64-year-old, and majority were females. They were right hand dominant, and majority had injury on their non-dominant hand. Now, in terms of findings, what we saw is there was decrease in pain and disability. This is the findings what we had at baseline. This is at 6 months, and this is at 4 years. There was marked decrease in pain and disability from baseline to 6 months. There was reduction in pain and disability from 6 months to 4 years, but it was not as much as we could see from baseline to 6 months, indicating, as already like explained in the literature, that majority of the recovery takes place after distal radius fracture in the initial 6 to 12 months. And this is what we could see over here. And next, when we looked in terms of fall risk factors, we saw that there was no marked change in physical activity over a period of time from baseline to 6 months or over 4 years. There was improvement in fall efficacy from baseline to 6 months, as well as from baseline to 4 years. However, there was no marked change from 6 months to 4 years. So that is, there was decrease in fear of fall over a period of time with no change in marked or significant change in physical activity. Now, in terms of health status, if we looked, there was improvement in both physical and mental health status over a period of time. However, mental health status, if we look over here, was same after 4 years as it was on the baseline. And this we thought is because of the physical nature of the injury. We saw this sort of changes. And then in terms of BMD and T scores, we did not find any significant change over a period of time. And while we looked whether these changes vary with age, gender, incident of secondary falls or fractures, what we found that there was no significant difference while we compared or stratified in terms of age, gender, or secondary falls or fractures for our outcomes such as pain and disability, physical activity, or fear of fall. However, if we look on the health status, we did find that people who had secondary falls or secondary fractures, they have significantly lower physical health status as well as mental health status compared to those who did not had fall or secondary fractures. So this was important finding. And to conclude from this study, what we found that post-distal radius fracture, majority of improvement in fracture-specific pain, disability, fear of falling, and health status actually completes at 6 months, and a very small change were observed during 6 month to 4 year follow-up. And people with secondary falls or fractures after distal radius fracture present with lower physical health status compared to those without secondary falls or fractures. So overall in this study, what we found is we had clinical benchmarks, that is how the trajectory of recovery would take place over a period of time, specifically in terms of fall risk factors, if we want to look for these patients if they are at any risk of secondary falls or fractures over time. Now, to answer second question, to what extent baseline modifiable risk factor could predict BMD in patients with distal radius fracture? We conducted another study, which was a cross-sectional study to look for association of modifiable risk factor with BMD, that is bone mineral density among people with distal radius fracture. Now, in this study, we used bone mineral density as our dependent variable, and we assessed it using DEXA. And then we used some independent modifiable risk factors such as balance, which was assessed using Biodex, knee extensor and plantar flexor muscle strength as a measure of lower extremity muscle strength, again measured using Biodex, hand grip strength, which was measured using a dynamometer. And I want to focus here, we measured hand grip strength on the unaffected hand at 3 months post-operatively. And we assess physical activity again using a self-reported questionnaire as explained before, that is RAPA, and wrist hand pain was assessed using self-reported questionnaire, that is PRWE. For analysis, we used multiple linear regression. And if we look on the results over here, I'll talk in terms of how we will associate these results. So if we look over here on the left side, these all are independent variables. And over here on the top line, we see are the dependent variable, that is bone mineral density at the femoral neck and bone mineral density at the total hip. What we see over here, R square explains the extent of variability explained by these independent variables. So we see over here among all the independent variable, for BMD at femoral neck, that is bone mineral density, both balance and grip strength were mainly explaining variability in the bone mineral density. However, lower extremity strength was also able to explain some extent of variability in the bone mineral density. If we look at the total hip, it's only grip strength and the balance which was able to explain some extent of variability in the BMD. Now, this was univariate regression. Then we did multiple regression, and more particularly when we conducted stepwise regression to find independent association of predictor variable with respect to the dependent variable. What we found for BMD at femoral neck, it was only grip strength which could independently associate with bone mineral density and could explain 17% of variability in the bone mineral density at femoral neck and 12% of the variability in bone mineral density at total hip. Now, we also conducted age stratified analysis for BMD at femoral neck, and what we found in the age group from 50 to 64-year-old, balance explained 10% of the significant variability in bone mineral density. And among 65 to 80-year-old, it was the grip strength, which explained nearly 32% of the variability. However, we did not conduct age stratified analysis for BMD at femoral at total hip because of the small sample, and we were not sufficiently powered. But overall, we could see among all the results that grip strength do have a significant association with bone mineral density at femoral neck. So to conclude, we found that unaffected hand grip strength is independently associated with BMD at femoral neck in people with distal radius fracture. And we were not surprised with this finding because we had previous evidence that grip strength has association with frailty, physical performance, or fitness. But this association or this evidence was not well proven in patients with distal radius fracture. That was the reason we conducted this cross-sectional study to have this evidence. And so what we concluded that therapists should actually consider evaluating hand grip strength of unaffected hand and balance as a preventive screening for postmenopausal women to identify those who are at risk of secondary osteoporotic fracture after distal radius fractures. Now, the third question was, to what extent baseline modifiable risk factors alone or after controlling for bone mineral density and non-modifiable risk factor can predict secondary falls and osteoporotic fractures at 4 years after distal radius fractures. So what we were focusing in this study, we wish to see if modifiable risk factor has some additional contribution over non-modifiable risk factor, because it's modifiable stuff what we can actually work on in terms of intervention. So we conducted this study to predict these risk factors for subsequent falls and osteoporotic fractures. And this was a 4-year follow-up study, so a prospective cohort study. So here, our dependent, that is outcome variable, were secondary falls and secondary osteoporotic fractures. And our baseline predictors, what we considered, were divided into 2 sections. One were modifiable risk factor, that is balance, assessed using Biodex, physical activity, assessed using RAPA, which is a self-reported questionnaire we discussed before, fear of falling, again assessed using modified fall efficacy scale, which was a self-reported questionnaire, knee extensor muscle strength, assessed using Biodex, hand grip strength, assessed using dynamometer, fracture-specific pain disability, which was assessed using patient-rated risk evaluation questionnaire, again self-reported questionnaire, general health status measured using SF12 questionnaire, and bone mineral density measured using gold standard method, that is DEXA. So non-modifiable risk factors, what we considered were age, sex, prior history of multiple falls. In terms of analysis, what we conducted was logistic regression. And if we look on results, what we found that we had 113 participants to whom we were able to follow up over a period of 4 years. And if we look on demographics, majority were in the age group of 50 to 64-year-old. They were females, and 34% had injury in their dominant hand. 23% of the people, they had prior history of multiple falls. And at 4-year follow-up, we found that 24% of the people, they had falls in the last 6 months, and 19% of people had subsequent fractures after first wrist fracture at 4-year follow-up. I just want to emphasize here, if you see over here, 23% of these people had prior falls prior to distal radius fracture. So now, if we look on the results, we first conducted univariate regression to find which were significant factors explaining higher odds of secondary falls. So among all modifiable and non-modifiable risk factors, if we see over here, what we found, it was people who had poor balance, who had osteopenia or osteoporosis, had high rate of wrist hand pain more than 81 points on PRWE at the baseline, and people who had prior history of multiple falls. They were around they had nearly 3 to 3.5 times higher odds of having secondary falls at 4 years after distal radius fracture. Now, if you look on health status, physical health status, or RAPA, that is physical activity level. Now, people who had poor physical health status or poor physical activity levels at the baseline, they also had higher odds of having secondary falls. They had nearly 5 to 7 times higher odds of having secondary falls at 4 years after distal radius fracture. However, this finding was not statistically significant, but this finding was definitely clinically significant because the effect size was more than 4.5 over here in terms of odds ratio. So moving forward, when we look over here, we had 3 models to see if there are some specific factors which could independently predict falls. So in the first model, what we did, we took balance, we took wrist hand pain and T-scores, that is from BMD, age, gender, history of prior falls. But in the first model, we took only balance and wrist hand pain, and this model was unadjusted for BMD, age, gender, or history of prior falls. We didn't include any of these factors, and we found when we didn't control for these factors, wrist hand pain could actually predict it like by 2.9% in terms of bone mineral density. Means people who had wrist hand pain of more than 81 points on a PRWE scale, they had 2.9 higher odds of having low BMD. Now, if we look on the second model, we see that we included BMD, that is, we included balance, wrist hand pain, but we controlled this model for bone mineral density or T-score. In this case, we could explain that it was T-score, that is bone mineral density, people who were osteopenic or had osteoporosis, they had 3.5 times higher odds of having low BMD. Now, if we look on the third model where we adjusted for T-scores, age, gender, and history of prior falls, we found it was actually history of prior falls, which was independent predictor of low BMD among all factors. Along with this, balance also independently predicted people with low BMD. And here, in terms of odds ratio, we need to talk in terms of like people who had history of prior falls, specifically for third model. They had 4 times higher odds of getting secondary falls. And in terms of second model, I would say people who had osteoporosis or osteopenia, they had 3.5 times higher odds of having secondary falls. And in terms of model 1, I would say people who had wrist hand pain of less than 81 points, they had nearly 3 times higher odds of getting secondary falls. Now, if we look over here in terms of secondary fractures, none of the modifiable or non-modifiable risk factors were actually significantly associated with secondary fractures. However, when we laxed the p-value to 0.1, we did see that people who were osteopenic or osteoporosis in terms of T-score at lumbar spine or total hip, they had 3 to 4 times higher odds of getting secondary fractures, but this was only clinically significant and not statistically significant. Now, if we looked on multivariate regression, again, we did not find any of the factors significantly associated with secondary fractures. However, we did see that people who were osteopenic or osteoporotic in terms of T-score at total hip, they had nearly 4.5 times higher odds of getting secondary fractures. But again, the findings were only clinically significant and not statistically significant. Then we looked on probability and discriminative ability of our models. Probability means here we can see that if we use our model 3, that is, we included all our modifiable risk factor and we adjusted for all other non-modifiable risk factor and bone mineral density, there's 90% probability that this model can actually identify people with secondary falls. Similarly, there's 44% probability that this model, that is model 3, can identify people with secondary fractures. This is not really good probability, but if we look over here, 90% model 3, if our model 3 explains 90% of the probability to identify those who have secondary falls, this is probably a good model to identify those who might be at risk of secondary falls. Similarly, if we looked on discriminative ability, here 0.79, what it indicates that it's nearly 79% of the people in whom this model can correctly identify that these people will have secondary falls. And here if we look, it's nearly 74% of the people in whom this model 3 can identify that these people will have secondary fractures. So if we remember, our model 3 had wrist hand pain, balance, and T-scores from BMD, had age, gender, history of prior falls. If we evaluate all these factors, then we will be able to identify that nearly 79% of the people, we can identify nearly 79% of the people who will have secondary fractures. We can identify nearly 74% of the people who will have secondary fractures. Now, to conclude from this study, what we found is history of multiple fall is an independent predictor of secondary falls in patients with distal radius fracture. Also, in clinical practice, we can say that screening of patients for prior falls, balance, fracture-specific pain or disability, and bone mineral density can be a useful strategy to identify those who might be at risk of secondary falls. Now, what this research project contributed to rehabilitation and clinical practice is we provided descriptive changes in terms of fall risk factors, which can be used as a benchmark by the clinicians. Secondly, we did provide some novel quantitative evidence for distal radius fracture rehabilitation that therapists need to primarily focus, along with wrist hand pain, on the fall and fracture screening. That is, evaluating the hand grip strength for the unaffected hand can help to identify people who might be at risk of low BMD. And secondly, screening of patients for prior falls, high wrist hand pain, poor balance, bone mineral density in routine clinical practice can help to identify people at risk of secondary falls and osteoporotic fractures. So, take-home message from this is definitely therapists need to focus on managing wrist hand pain and other complications in patients with distal radius fractures. But I would say along with that, therapists should take this as a priority, that they should try to screen their patients with distal radius fracture, whether they are at any risk of secondary falls or secondary osteoporotic fracture, and should give appropriate referral for detailed bone health assessment for these patients if needed. In terms of limitations from this project was we had small sample size for some of our studies, and due to which we could not generalize our findings. And in terms of reporting of falls and osteoporotic fractures, this was done by self-report, due to which there is probability that we could have missed some of the fractures, such as vertebral fracture, which we can actually identify only using X-rays. So in terms of strength, it was a long-term prospective cohort over a period of 4 years, and we used quite reliable and standardized methods for the outcome assessment. In terms of future direction for researchers, I would say that we do need prospective large sample studies to establish conclusive evidence on the causal relationship between bone mineral density and grip strength and other modifiable risk factor, which we discussed. And we need to establish validity of the cutoff scores for individual modifiable risk factors, more specifically regarding the cutoff scores, which we have used in our third study, where we try to identify the risk factors for secondary falls and secondary fractures at 4 years after distal radius fractures. So I would like to definitely thank my PhD supervisor, Dr. Joyce McDermott, my committee members, Dr. Norma McIntyre, Dr. Grewal, Dr. Beatty, for all their support while I was involved in this research project. And I would like to thank you, Kavita Raja ma'am, for inviting me in this international speaker series. And thank you, Pallavi and Kundan, for all the tech support and helping me out with this webinar. And thank you to all the funding agencies who helped me to conduct this research project. And I'm open for any questions if anyone is having right now.
So Neha, can you tell us what from your research would be something that we would practice in India, for instance? Because our distal radius fractures are usually below the age of 85. Mm-hmm. Your highest numbers were between 64 and 85, right?
50 to 64, depending on study, because I had actually more than 50 years, and like primarily if we look in terms of incidence, it's post-menopausal women, like after 45 and 50, we see like it's after 65. I don't have many cases. It's between 50 and 65 what I had more incidence actually.
Okay. So what would be rehabilitative strategies? Regular stuff like weight-bearing exercises or anything specific?
Yeah, I would say based on my study, I can't say what would be the interventions, because right now I have only tried to identify the risk factors. So there are more studies needed to actually provide a conclusive evidence that this particular exercise would be effective in improving bone health in these patients. But however, what I could say in terms of rehabilitation, definitely the normal form of rehab, what we say like immobilization over 3 to 6 weeks, followed by like wrist hand pain management. But along with that, when the patient comes to you as a therapist, it's very important that do a simple measurement of grip strength of the unaffected hand and see if it's less, it means they are probably at risk of low BMD as well. And also do some assessment in terms of like PRWE scores, because I did in this study more than 81 points. If someone is scoring more than 81 points, it means there is some indication that they might be at risk of secondary falls based on model 1. Or simply ask one single question, which will take a second of time, any history of prior falls, because this was found to be a significant predictor of secondary falls in our population and many other cases. Like asking just simple question, if we see like 25% of our own sample had prior history of secondary falls. So just asking this question gives a good indication that they are at risk of secondary falls. And then in terms of management, I would say do a holistic approach to them. Why they had a fall? Check their balance. They had a first fall. Not everyone falls and get break in the bone. It's because they had some issues in their bone health ahead of what they like ahead of this fracture. So probably they had poor bone mass ahead of this fracture. Probably they had poor balance. Probably they had less muscle strength. So assess all these factors as a holistic approach rather than just assessing wrist hand function.
Do you have any numbers on previous falls? How many previous falls? Do you have any numbers? Is it
yeah,
one fall prior to, I mean, when you say previous falls, one fall, multiple falls, once in the last 6 months?
So like yes. So in my project, what I asked my subjects is more than or equal to 2 falls in the last 6 months. So if they said yes, it means based on my third model, that was an independent predictor of secondary falls actually, and could explain that 90% probability that this model could predict secondary falls.
That is more than 2 falls in the last 6 months.
Yeah.
Okay. And this held good even for the younger population, like this 50 to 64?
I had sample from more than 50 till 80, 50 to 80.
I'm interested because I'm in that age group, right?
Yeah. No, I don't want or don't wish this to be for you.
No, anyway, jokes apart, when you say unaffected hand grip strength, what percentage from normal deviation are we looking at?
Yes. So this is an important point which I could not talk too much in this presentation, but this is very important in terms of clinical practice, that when we are looking on unaffected hand grip strength, we need not compare in terms of affected hand grip strength. We need to compare it with the normal. What are the norms? So how much it deviates from that norm, that's what, if it deviates from the norm, it means there is decreased grip strength. But I cannot say the cutoff. I cannot say the cutoff because it was just like.
So what was your finding? Study. What was your finding, roughly, median?
I did not find deviation from normal, like from the norms. This is what I could propose for future research that they should find.
Okay, because you know that we don't have norms in India, right?
I'm not sure about in India.
We didn't have when you were an MPT student, and we don't have it now either. We just have very small sample sizes. So we would still be considering the established norms.
Mm-hmm.
And when you say balance, you looked at biodex. So if you're looking at clinical measures of balance, we would use DBS, correct?
Use timed up and go or like any simple, because I would say timed up and go. Why I would recommend, because one of my own colleague, he actually found this test as a reliable and valid for people with distal radius fracture. So in context of population, I would say, because it's not possible practically to use biodex in every clinical setting. So this is the recommendation what we would give to clinicians.
Okay. So timed up and go. So in short, you're saying that if any patient comes to us with a forearm fracture, we should not focus just on the forearm fracture rehabilitation. We must look at the whole person approach. We must also look at balance issues, intrinsic and extrinsic factors for falls. We must look at the other grip strength, etc. And we must also follow up beyond the acute care. Is that what your recommendation would be?
Yes, in simple words.
Okay, because we have third year students and I wanted to put it in normal language.
Yeah,
agree. Is there anything else you would like to share?
For
India.
I can specific to India. Okay, no, I was about to show you guys one slide. Maybe I can show you just to give you a better picture of what I'm saying. Like, but this is a sample from here, Ontario. This is just to emphasize, like, it's a real scenario that these people do have poor bone health. So if we look over here in my sample at baseline, you will see in terms of lumbar spine, total hem and femoral neck, you will see that nearly like at baseline, 40% of the people, they are having osteopenia or osteoporosis at baseline. But if we look at 4-year follow-up here and here, if we look 6 plus 66, like nearly 75% of the people that have osteopenia or osteoporosis at 4-year follow-up, starting from 40% at the baseline.
So you're saying after a distal radius fracture, their bone health is decreasing significantly.
Yeah, like this is from a small sample, and there are other studies which do say like nearly 80 to 90% of the people, they have low bone mass after distal radius fracture, and more specifically in postmenopausal women. And if we see my sample, majority of them were women actually. So it's really important to focus on bone health along with other things. This is what I would like to convey from this project to students in terms of their clinical practice. Yeah.
Thank you. Any other questions, Pallavi?
Yes, ma'am, there are some questions for you. The first question is, what would be the goal of treatment on RSD?
Goal of treatment on RSD would be symptomatic, I would say. I have not focused on goal of treatment for reflex sympathetic dystrophy in this project. However, whatever management you're doing in terms of like managing stiffness, managing pain, managing swelling, managing hypersensitivity, that would continue as you might be already continuing in your clinic. And you can emphasize on weight bearing along with that. Yeah.
Previous one. There is another question. Importance of hand function in distal radius fracture.
Sorry, what's the question?
What is the importance of hand function in distal radius fracture?
Okay, I would say it's all hand function in distal radius fracture. So everything is important because after distal radius fracture, if your hand function is not proper, you cannot use it for your functional activities. So in terms of hand function, there should be reduction in pain so that you can do other exercises to reduce your stiffness, to reduce your swelling. And yeah, then only you can use your hand functionally. And yeah, I'm not sure. Can you clarify the question more?
Ma'am, the question is like, what is the, like, how important is hand function post fracture?
They're probably meaning how much concentration would you pay on hand function versus regular approach. That's probably what they mean.
Yeah, so sorry for this confusion. I would say hand function is definitely a top priority after distal radius fracture. You cannot focus on bone health and leaving hand function aside. So definitely initial weeks, I would say after like post immobilization, after 6 weeks, patient would be, once optimal healing is recognized on x-rays, patient would be referred to you for improving wrist hand function, where you'll be primarily focusing on modalities for relief of pain, using some hands-on treatment to reduce stiffness, as well as for swelling, you'll be managing something. You'll be doing some sort of stuff for reducing hypersensitivity. And by 12 weeks and over a period of 3 months, like you'll be focusing primarily on improving the hand function. And once you see your hand function is good in terms of muscle strength, in terms of range of motion, in terms of pain levels, you'll try to include your hand more in terms of functional activities. And while you're doing all that, at the same time, while the patient is visiting your clinic for general assessment as well as treatment, you can also start evaluating patients for all other fall risk factors as well as risk factors for secondary fractures to see if they also need referral for detailed bone health assessment over a period of time, so that they should not suffer with any secondary falls or fractures after this distal radius fracture.
Ma'am, the next question is, anyone? Okay, ma'am, the next question is, a patient coming after a surgically treated distal radius fracture with complaint of reduced range, reduced strength and reduced hand function. So which part to focus first, whether it is the range, strength or hand function? And how long should we treat it?
Range, strength and hand function. I would say first you need to focus on range and strength simultaneously. You need to first get some range, right? Some mobility at the joint. Once you have enough mobility, then you have to increase the muscle strength. And then once you have adequate mobility at your joint surfaces, you have adequate muscle strength, that's when you can start involving your hand in functional activities. Yeah, this is the sequence what they have asked, or am I clear?
Yeah, ma'am. They have asked for the sequence and how long, because the last thing is hand function. So how long should we be dealing with the case to gain back the hand function?
I would say I don't have current evidence like in 2020 what's happening, but I would say based on my clinical experience, most of the patients should gain hand function by 6 months, and at the most they should recover to their sport or normal functional activity by 12 months for sure. Yeah.
And the last question, any specific treatment protocol recommended for pediatric population, mainly 8 to 12 years with distal radius fracture?
I wouldn't like to answer to this question because I don't have current evidence on my head right now in this area. Sorry.
Wants to answer?
I'll answer that. There's nothing specific in pediatric, and they rarely get distal radius fractures unless it is a high level injury, high force injury. Most of the fractures would be supracondylar fractures, and that's the normal management, whatever we do. Children rarely get distal fracture unless it's an accident, in which case you would manage it as per the current, as per that individual's requirement.
Any question? Okay, ma'am, that's it. So thank you, ma'am, for this very informative session. So I hope so definitely bring some changes and the quality of our patient care will improve after listening to this. Thank you so much, ma'am, for your valuable time.
Thank you.
Thank you.
Thank you, ma'am. So am I good to leave the session now?
Yes, you can.
Okay.
Thank you very much.
Thank you, Kundan. Thank you, Pallavi. Thank you, ma'am. We'll talk to you soon. Bye.
Bye. Have a good day.
You too. Bye.